All right, welcome everyone. I am Jonathan Purtle. I'm an assistant professor here at the Drexel University Dornsife School of Public Health, and I will be a moderator and presenter of today's webinar, Population Mental Health and COVID-19. We are very lucky to be joined by two wonderful panelists on this. Dr. Wanjiku Njoroge. She is a psychiatrist and program director in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at the Children's Hospital of Philadelphia, and Dr. Sosunmolu Shoyinka, who is the Chief Medical Officer of the Philadelphia Department of Behavioral Health and Intellectual Disabilities Services. So I will give a brief, broad 10-minute overview, and then I'll pass it over to the speakers, and then we will have time for some Q&A. So while I was looking through my slides, getting ready for this, I got a text from my mother-in-law telling me that the UN had recently just warned of the great mental health fallout from the pandemic. So this is from the New York Times about 1 hour ago, but it was very timely given the topic of this webinar, and glad to see global public health officials starting to speak about and think explicitly about the mental health fallout and consequences of the pandemic. And I think in a lot of ways, we can think of the physical morbidity and the mortality related to COVID-19 as really just the tip of the iceberg. There will be profound consequences for mental health, social consequences, of course, economic consequences, but those will become manifest in social and mental health consequences. So the purpose of this webinar is to really just kind of open up lines of communication and try to get people thinking about if and how the pandemic could impact mental health, and then bring some perspectives from the front lines in Philadelphia about how the mental health consequences of the pandemic have been addressed. So just broadly, a few definitions. So what is population mental health? What are we talking about? So we're talking about the distribution and determinants of mental health status among a group of individuals that are shared by a geography, that may be Philadelphia, that may be the United States, socio-demographic characteristics, could be race, ethnicity, income, health status, or source of clinical service utilization. And the real focus here is on groups, not individuals. So, this is a public health approach and public health thinking to mental health. And the focus is on policies and structural factors, thinking about macro and how macro factors influence mental health, as opposed to just thinking about clinical interventions in isolation. And most importantly, what is mental health? What are we talking about? I think it's really important to emphasize, mental health is something that we can think about along a continuum, ranging from a mental health condition that meets the full criteria, DSM criteria for a specific mental health condition, to flourishing and doing really, really well on the other side of that. So we could say maybe, doing okay, very, very scientific construct, lies somewhere around there. And over here we have the more technical and real construct of psychological distress. So the key point when thinking about mental health is we need to think about it as occurring on a continuum, and it's also something that's dynamic within individuals and not fixed. To that point about dynamic, we're still, with all things COVID related, data are still coming in. We're still trying to understand its effects. The same is true for mental health. This was a large survey by Pew that they did. They did it in March of this year, March 19th through 24th. And then they went back and contacted the same people a month later in April. And the interesting thing here is, as the heading shows from this graph, is that, when we look at just the prevalence of psychological distress over that month period, the crude prevalence did not change. It was 24% in March and 24% in April. But what's really interesting here, when you look at how these different shaded lines move to different categories, we see the dynamic nature of psychological distress during the pandemic. Some folks moving from high to medium, high to low, low to medium, low to high. The extent to which people's mental health is being impacted by this is dynamic and changing over the course of the pandemic, and it will continue to do so. Also, when we look at these data a different way, we see that psychological distress is strongly associated with the extent to which the pandemic is having financial implications for folks. So folks who feel like the outbreak has hurt their finances more than most people, 57% of those people had high psychological distress compared to those people who said less, which is 28%. We see the same thing when looking at the ability to pay their bills this month. And then we see a much weaker association when we look at the role that the number of COVID deaths in a county and how that is associated with high psychological distress. We do see an association, people in counties with 0 to 10 COVID-related deaths, 30% of them having high psychological distress compared to 37% in those in counties with more than 200 deaths. But the magnitude of that association is much weaker than that for the financial impacts of the pandemic. And lastly, this is another survey by the Kaiser Foundation. They asked folks explicitly the extent to which they thought that worry and stress related to coronavirus has had a negative impact on their mental health. So here, this is just a single item, but we see about 45% of the US population saying it's had a major or minor impact. And then we see it being slightly higher among females than males, and racial and ethnic minorities than non-Hispanic whites. So I just want to talk a little bit about the who and then a little bit about the how COVID could impact mental health before passing it over to speakers. So who is at risk for poor mental health because of the pandemic? Well, everyone, because it's a pandemic. And that's one thing that's truly unique about this public health emergency. Everyone is being affected. That said, thinking about population mental health and thinking about populations in different groups, there are some groups I think we should give particular consideration to and think about ways that the pandemic could be impacting their mental health. So one such group is people who had poor mental health prior to the pandemic, which is about 19% of the US population has a diagnosable mental health condition. And of that 19%, 4.5% has a severe mental health condition. And then we can think about those folks in terms of those who were and were not receiving care prior to the pandemic. So among those with a diagnosable mental illness, less than half were receiving care. Those with severe mental illness is about 2/3. But thinking about people who were in care and may have really, really needed that care, how that care has been continued over the course of the pandemic. Of course, essential workers, something that has been in the headlines a lot and obviously very important to think about. Of course, healthcare workers on the front lines, but I also think it's important to keep in mind there are lots of other essential workers who are working and have that potentially that elevated stress and anxiety. So this is from the Times. The purple bar shows the proportion of each one of these types of workers that is female, the total number of workers in each one of those sectors. And the number, we see healthcare workers by far the largest number, but it's still less than half of the essential worker population who is out there and potentially experiencing stress and anxiety related to that. Of course, folks with financial insecurity, and here we can think of people who were financially insecure prior to the pandemic and those who have become financially insecure because of the pandemic, with rising unemployment rates and furloughs and lost wages. Absolutely a group of individuals to keep in mind. And lastly, people who are socially stressed because of quarantine. I think it may be fair to say everyone is somewhat stressed in the time of quarantine, but thinking about at least two distinct groups. We have folks that are very socially isolated because of quarantine. Pre-COVID, that was almost a quarter of US adults over age 65. And also, there are people on the complete other side of that continuum who are socially cramped and are in houses with a ton of people, which is also extremely stressful, potentially, and not great for mental health. And lastly, building on the who, the how, there are many, many ways that we will not talk about, the mechanisms and pathways through which COVID-19 could negatively affect mental health. But I just want to highlight a few of these from an equity perspective. This piece was published in JAMA a few days ago by David Williams and Lisa Cooper. It's one of the better things I've read about COVID and health equity. They make a lot of great points, so I just want to throw that out there. But it's not focused on mental health. And I kind of want to extend some of these ideas to mental health real quickly from a a population and equity perspective. So one is grief stemming from COVID-19 related mortality. So we know that the sudden death of a loved one increases risk for a range of poor mental health outcomes. This is well known. There have been a number of large population-based studies where they ask people about a range of potentially traumatic events. Has that happened to you, yes or no? And then they ask them, say, of all those that have happened to you, which one was the worst? And the one most frequently rated by a person as the worst was that sudden loss of a loved one. And why that matters for COVID from a mental health equity perspective is that we have these disparities in mortality rates. So as of now, the best data we have, the COVID-19 mortality rate for Black Americans is 2.6 times higher than that for non-Hispanic whites. So psychiatric epidemiology tells us that will probably become, or has a potential to become, manifest in disparities in mental health outcomes as well. Of course, as I alluded to, financial stress related to unemployment and lost wages from the pandemic. We know very well that financial insecurity increases risk for poor mental health. And we also know that Blacks and Hispanics are overrepresented in industries that have laid off lots of workers and at the highest risk of job loss because of the pandemic, while non-Hispanic whites are underrepresented. We also know that these workers had lower wages prior to the pandemic than workers in other industries. And lastly, social isolation. This affects all classes, all races. We know that it increases risk for poor mental health, but we also know that audiovisual technologies can reduce that isolation. But we have a digital divide which persists despite smartphones and more broadband internet. Low-income individuals who are disproportionately of color have less access to these technologies. So just for example, these are data from Pew. 56% of people with an income less than $30,000 a year have broadband internet. 71% have a smartphone, compared to nearly 100% of those with income 100,000 or more. There are many, many examples that could be provided, but I think thinking in these sorts of ways when we observe an impact of the pandemic that we think may have a disproportionate impact on some groups, thinking about how that may become manifest in risk for poor mental health over time as well. These slides will be available. I just wanted to share there have been a number of great pieces, very interesting and thought-provoking pieces published recently, all about COVID and mental health that I encourage interested folks to check out. And yeah, the vision for me is largely tip of an iceberg when thinking about the health consequences of COVID. And hopefully this tip of the iceberg visual may turn into silver lining. Perhaps there will be some good for population mental health that comes from this, but right now it seems to be focused on the negative and the potential consequences. So with that, I will stop sharing my screen and pass it off to someone much more on the front lines to share her perspectives. Dr. Wanjiku Njoroge.
Hi, everyone. So let me get my screen set up. Okay. So I'm very excited to be a part of this panel. So I thank you, Jonathan, for inviting me to give a little bit of a glimpse into what life has been like at CHOP. So as Jonathan said, I'm Wanjiku Njoroge, and I'm an infant preschool psychiatrist. So the kiddos that I see are all under the age of 5. I'm also the program director for the Adolescent Psychiatry Fellowship at CHOP. I'm faculty at the Policy Lab, and then I'm assistant professor at Penn in the Department of Psychiatry. So what I hope to do over the next little bit of time is to take us back to the beginning of this pandemic. So it now seems so long ago, but if you can think back to mid-March when things started, I really would like to have us envision what we were all going through at that period of time when both the mayor and the governor ordered stay-at-home orders. At that time, no one really knew what was going on, and we really did not know what was coming next. And that really was the beginning of how we ended up thinking about how we could continue to be helpful for children and families as we began on this journey of trying to figure out how to be responsive during COVID-19. So there were basically 5 main interventions that CHOP did, specifically my department, the Department of Child and Adolescent Psychiatry and Behavioral Sciences, that I want to spend a little bit time talking about. I think Jonathan gave us a very nice overview of how we should be thinking about this from a population mental health perspective. I'm going to bring it down just a bit to think more about the children and families that we serve in our department at CHOP. So these interventions are happening really pretty simultaneously, and I really would like to walk you through what we were thinking and how we were trying to address this pandemic through our initial responses, through the ways in which we tried to make accommodations that Jonathan also referred to in his talk, thinking about some of the really innovative things that had to happen because we were doing things differently through partnerships across state lines and thinking about ways in which to partner with providers and families, and then really trying to get down to the nuance of what we knew families would most likely need as we continued into delivering services throughout this period of time. So we started a little bit before the state and the city shut down. For many of the hospitals in the area, we knew what was happening, right? We could all sort of see what was happening, particularly with our neighbors in New York and New Jersey. And CHOP really began to very quickly mobilize and think about what we needed to do in reaction to the pandemic. And when we did not know how this pandemic would affect children and families. And one of the things that CHOP decided to do, as did many hospitals across the country, was really to try to limit the amount of people that were on campus. And so that included rescheduling all kinds of non-essential surgeries, and as well as planned admissions and or outpatient visits. Our department specifically really thought about what we needed to do to really limit our footprint on campus. And again, to rethink about ways to maximize physical distancing. Everyone was very concerned at that particular point in time about personal protective equipment and would there be enough, not knowing the numbers that we were facing, and really thinking about how to create appropriate safety protocols in spaces where we often shared workspaces and equipment and had many families waiting in the same spaces together to be seen by their providers. So really throughout all of this, we have remained open. So our outpatient behavioral healthcare sites and many of our inpatient and community programs have continued to see children. I think what's really been important about that is that with knowing what we knew then and know now about the way in which this virus spreads, we had to be very thoughtful about how that would work. And that included really thinking about the clinical picture and what children really were best served by physically coming into our spaces and the services that were provided in person, while continuing to think about other ways to provide services for patients that may not need to be seen on site. So again, we continue to see children, though our services were truncated. So we weren't open as frequently as we had been. Part of this was really due to, again, limiting the amount of clinicians and staff that were on site, as well as allowing opportunity for cleaning and all of those kinds of things that everyone's really tried to be very thoughtful about. So again, at sort of the very beginning of this and before the state and the city officially shut down, we began to realize that there were differential risk in different areas. So we see that, we talk about that a lot now, and at the very beginning, that wasn't as readily apparent until we started looking at the data of where people were coming to the hospital and from which regions and locations and parts of the city and state that was happening. And that really led to more thought about looking at these high-risk areas and really beginning to develop safety procedures for the patients that were coming from these areas that we knew to be high risk, but that they would require inpatient hospitalization. And this was both for pediatric hospitalization as well as child psychiatry hospitalization. We also were developing policies to think about the children that we were trying to safely maintain out in the community that had these pre-existing mental health needs in the face of COVID-19. This led to a lot of both challenges and innovation, which I'll talk a little bit about. Some of the things that were concerning when we're thinking about inpatient child psychiatry, in which case CHOP partners with Belmont Behavioral Health, was really thinking about, these are children who needed acute hospitalization. These are children who could not be maintained safely at home and really needed to come in for treatment and for care. And therefore, there needs to be some sort of screen. These children needed to be in the hospital, but we also need to recognize who of those children were COVID positive and who were COVID negative. And that led to a lot of thought about the kinds of screeners that we needed to use as information began to gather that changed the picture from international travel to community spread, as we began to really understand the ways in which children were at that time we thought impacted by this disease. And it led to this formation of a task force that really met multiple times throughout the day, each day of the week, and did safety planning as the clinical picture continued to change. One of the things that happened during these meetings was really leading to understanding that the children who ended up becoming COVID positive or who came in COVID positive really needed to have a space where they were not going to be vectors for the other children who were COVID negative. And that led to the creation of a unit that was just set up for COVID positive children, and that had their own sort of separate staff that saw to those children, so there wouldn't be this concern of cross-contamination. And again, there were all kinds of innovative work that happened on that unit that still allowed the children to participate in all of the therapeutic services that they were in the hospital to receive. And then some of the stories that have been told by that unit included the music and the art therapist really trying to figure out ways in which they could continue to provide services with children who weren't able to be close to them. And that consisted of them doing some of this stuff in the actual hallway with the children in the doorway, so they were still able to participate and gain the benefits, even though they were different than they had been prior. This also sort of simultaneously led to this rapid conversion into telehealth. I mean, we just heard Jonathan talk a little bit about the importance of tele platforms, and clearly we're using one today. But again, all of our divisions very quickly switched to using this modality. And that was by no means a small undertaking. And I'm going to walk you through a little bit of that data right now as well. So as you will see here, this is the very beginning of the pandemic. So this was right in that sort of March 17th, when CHOP started to rapidly convert all of the inpatient services into other kinds of services or at other times. And our department has over 100 clinicians that are seeing children in various different clinics all across the city and region. So all of those services still needed to be able to be offered to children and families. And we really then had to go about ramping up training for all of these over 100 clinicians to be able to understand how to be able to conduct the work that they had been doing using tele platforms. So you can see that this team did an amazing job. I have just given some pictures here of the inpatient video visits, the community video visits, and the outpatient video visits. And you can see, again, if you remember that slide from where we began to kind of where we are now, it's actually really fairly remarkable, but what has happened in such a short period of time, considering that the majority of providers had not done any video visits prior to the pandemic. This again will show you, this data is up to last week, where it will always be a little bit delayed. But again, you can see, thinking back about that March 17th data to where we are now in April and May. And this next slide just really highlights how many video visits have occurred over the course of the past couple of months. And that we've been able to provide services to over 5,500 families and children through these video visits. And again, last month alone, there were almost 4,000 video visits. So that's actually quite remarkable for almost 200 clinicians. And again, I will say that CHOP is not alone, and our department, DCAPS, is not alone in its ability to rapidly respond, but it is remarkable considering that this was not on the plan for certainly not now. And then again, with the rapidity that we really needed to ensure that this platform worked. There were so many people that were using it, and there were so many families that were really depending on it. Other things that happened that were really very unique happened all across the country. There have been barriers in the ways in which services have been able to be provided for children and families. And part of that is just across state lines. And so one of the things that we recognized quite early on was that many of our families lived in different states than the providers. And so now that everyone was sheltering at home, if there was a Pennsylvania-based provider who'd been seeing a family from New Jersey who'd been driving into one of our clinics, how are they going to be able to provide services when that family was now based in New Jersey? And so there were all these collaborations and partnerships with states that allowed this work to happen, so the provider could be in one state and the patient in another. And again, that really allowed many families to not lose or miss their ability to continue to be seen as they had been seen prior to the pandemic. Furthermore, what we recognized is that families needed a lot of support. I mean, behind the scenes, the DCAP staff was working exceedingly hard to get these platforms into place, to get all of the clinicians trained up, but the families also needed support in how to even access these services and whether or not they wanted to continue to access services through CHOP, or whether they were better served through community providers. And so those discussions happened throughout the days and evenings, even on weekends, as the DCAP staff really tried to ensure that children and families did not stop receiving their services because we were in the midst of this pandemic. This also led to DCAP's staff having to really work with families on how to even access these portals. All of these teleplatforms for our patients were really sort of embedded in our electronic health record. And so to be able to access that, the parents had to have signed up at some point prior to be able to access this portal. And some parents had that portal already live and then were very easily able to go in and speak to their providers through the embedded link, whereas other families had never set that portal up. And so our staff really worked exceedingly hard with families to ensure that they knew what they needed to do prior to the appointment, working with them to make sure they understood, as well as brainstorming with what if there's a glitch. We've had some really horrible storms, and particularly at the very beginning, when there was such a great demand for these platforms, there were problems with services. And so what happens when you're talking to your provider and the provider freezes, or the provider can't hear you, or you can't hear the provider? So we needed to work not just with clinicians on how to brainstorm and how to problem solve, but also with families of what do you do if you're in the midst of talking about something very concerning and all of a sudden your provider is gone. So again, the DCAP staff created all kinds of flow charts and triaging with families on if this, then here's what to try first. And then if that doesn't work, then here's what to try next. So again, there was a lot of behind the scenes work that really made all of those visits I just showed you possible. Furthermore, for our families that were being seen in our partial hospital program, which is out in Mays Landing, these are children that were being seen 5 days a week for school hours. So many of them were there at the partial program from 8 to 3. So now that that partial was no longer running, where were those kids going to receive those services? I mean, those kids had been in the partial program specifically because they didn't require acute inpatient care, but they also weren't quite at the point of being able to see a provider on a weekly basis. And so they really needed to think very carefully about how they would continue to offer this very high quality service, particularly to community that may not have had all of the technology that would be required to be able to be seen through these teleplatforms. And this again speaks to what Jonathan talked about with the digital divide. So what the team at Mays Landing thought about when they were thinking about the population of patients that they serve was that families needed iPads. They needed an absolute way that they could communicate with their providers on a daily basis. And so they got iPads for every single family that needed an iPad to ensure that treatment wasn't interrupted. They also realized that by doing so, that families that had had difficulty participating in the partial program prior to the pandemic were now able to do so with this technology and with this increased access. But Mays Landing recognized something else about the families that they served. they recognized that many of those children were receiving breakfast, lunch, and snacks while they were at the program. And so they realized that families were now struggling with having meals that they had not previously had to arrange. So that team also arranged for the bus drivers that had been the ones picking up those children and bringing them to the partial program, and knew the families, knew where these children lived. That same drivers were then able to deliver food from the food pantries to the families. So that team, I really wanted to highlight, because I think their innovation, their creativity, and their really understanding the population and the families that they serve really engage in this really wonderful way to ensure that not only were these children and families still able to receive the same high quality care, albeit differently, but also that they recognize some of the other needs that families had that lead to the stressors that, again, Jonathan talked about when he was setting up this discussion. So where do we go from here? As we all know, the state is planning on opening up on June 4th, and many of the businesses are slowly starting to think about what happens next. For us at CHOP, we've already begun to increase our presence and our footprint on campus by starting with some of those elective surgeries that had been rescheduled, starting to bring those children back in, recognizing that they could no longer continue to wait, and that the longer that those surgeries weren't scheduled, the more concern there was of how those children would fare. So there are things that we should really think about when it comes to children's mental health. And I think part of this is looking at some of our colleagues who are ahead of us in this pandemic. And so this is an article, or actually a research letter from JAMA Pediatrics that came out the very end of April. And I want to put this up here because I think there are some things from this that we should consider when thinking about our children in Philadelphia and the Philadelphia region. So this study was from the Hubei province and had over 2,000 students. But the takeaway points that I really wanted to point out were sort of two things. One, and this was, I think, a question that was asked earlier prior to this discussion, the question was about what does the inability for children to go outside do to their mental health? And what this study has begun to tentatively question is that there may be a possible link in their in that population of children with a reduction in outdoor activities and social interaction with an increase of depressive symptoms. They also saw an increase of anxiety symptoms in the same population. Now, one of the things that they're very careful to say when you read this letter, which is really quite brief, is that what they don't know is what that means for later. That's how these children were doing at the time when the children completed the surveys, but it's not quite clear rather, how that will play out over the weeks and months ahead. So I think that's one thing for us to keep in mind. The other thing that I think we should consider for thinking about children and our children, specifically in this region, is the impact of school closures. So we just heard about the data out of China, but let's remember that for many children in our area, schools are closed through summer, and it's not quite clear what might happen with summer camps and summer programs where children usually spend time. We also aren't quite sure what's going to happen in the fall. Many schools are wrestling with what to do, how to begin. There is a concern there might be another peak in the fall. What does that mean if there's another school closure? So these are all things that we need to consider and things that we just don't currently know the answers to. We also, as Jonathan highlighted earlier in his talk, know that there's been a differential impact across children. And so we need to take into consideration what that might mean for children's mental health. And will we see that differential show up in those children over the weeks and months ahead as well? I highlighted the collaboration that happened fairly rapidly across states and across community agencies, really to ensure that children did not lose services. Will those collaborations be able to continue? Were those collaborations made so readily and so easily now be able to be sustained over the weeks and months ahead? And then again, there's this question of children who had prior mental health disorders. Will they be worsened? There's some suggestion that they might, but again, that data is based on children who've been quarantined with illnesses for a period of time. But again, we're talking about all children who have been sheltered at home and who haven't been attending school. So will that make a difference? And again, this relates back up to the differential impact. Will all these other factors that Jonathan so described, this multifactorial picture, what does that mean to children who had prior mental health disorders? Again, these are questions that we will have to answer and data that we're going to have to gather as we continue to see how this picture unfolds for us all. And so I want to end by just thinking about, as we're slowly reopening and beginning to do more in-person services, that we will probably still use some of these same platforms that we found helpful. As we know, physical distancing will still be in effect, PPE will still be in effect, so we won't be able to return to business as usual. I think we all know that now. And children and families know that as well. And so again, we will be able to really use what we've learned over the past couple of months to continue to help children and families. And that really is the goal, is that we're able to continue to support children and families and all of us as we navigate what we're now calling the new normal, the COVID-19 future. So with that, I thank you for your time, and I will pass this back to Jonathan to take us to the next talk. Thanks.
Wonderful. Thank you so much, Dr. Njoroge. It was great to hear that perspective. Dr. Shoyinka, the floor is yours.
It's a pleasure to be here with you all. Dr. Purtle, Dr. Njoroge, thank you for your wonderful thoughts and ideas that you shared. And certainly it was very interesting hearing in more detail what's been happening at CHOP. I'm just going to share my screen here real quick. So I'm going to be sharing what Dr. Njoroge did was to, if I may put it in this way, was to give us a very sort of focused view of interventions on the front lines, as she said. What I'm going to do is zoom back out a little bit and look across the city of Philadelphia at what I will call Philadelphia pre-COVID and some of the population level interventions that have been made by the city and more specifically by DBHIDS through the COVID response. So let me lead in by saying that pretty much I would say everything that DBHIDS does targets is population health. It's really focused on population health and there are targeted interventions, for specific groups. And then there are the broader system level interventions that would include things like access to health care services across the board. There will be, and then there will, ensuring quality of care to all populations served and so on. I think some of the important pre-existing conditions, if you will, in Philadelphia that I think are particularly pertinent when you look at this through a population health lens are Philadelphia has the unfortunate distinction of being the city, the largest city. If you look at large U.S. cities, Philadelphia has the greatest degree of poverty among large U.S. cities, and we know that poverty is a tremendously significant social determinant. We also know that Philadelphia, like many other big cities, could really be described as a traumatized environment. All you had to do prior to COVID was turn on the news and read about gun violence and so on. And that sort of daily exposure is really important, I think, as a precursor to the sort of large-scale traumatic impact of an event like COVID. I think we also know that there are also other social determinants. And then there is also the fact of the city of Philadelphia being, having one of the highest rates of opioid-related deaths in the country. So all of these existed before COVID. And I'm happy to say that DBHIDS has been involved in efforts to combat certainly the deaths from the opioid epidemic, and a number of other high-level efforts to address these social determinants, including trauma. Trying to advance my slides here. Give me a second here. I'm having some trouble advancing my slides. Give me just a moment, please.
I found that I needed to use, when I was presenting, I don't know if you have a mouse with a roller ball on it, but if I used the roller ball, that was working for me. For some reason, the click was not working for me. So I was rolling down to advance one slide.
Well, let's try doing it this way. Okay, so yeah, there we go. So in the era of COVID, there are certain populations that are more vulnerable than others. You talked about quite a few of them, Jonathan. You talked about the pre-existing situation within the African-American community that has led to the higher rates of death from COVID and COVID-related causes. But we know that other populations are at similarly high risk and have been particularly impacted by COVID. So we know individuals struggling with addiction. COVID has had a disproportionate impact on congregate settings. I think we've seen that in the news. Behavioral health providers and all providers, I think, have been impacted, but particularly for those behavioral health providers that are servicing those individuals that are homeless or living in congregate settings, this has been a unique challenge. And then we've seen the same sort of impact in our re-entry, returning citizens, and certainly in Kensington. So what are some of the things that DBHIDS has done? We have a plethora of programs that have continued to operate throughout this period. Obviously, we've had to make many of the same adaptations to COVID that have been reported at CHOP. So helping our provider network as a whole move to telehealth has been I would say actually a welcome and much needed intervention. And you might know that the federal government relaxed guidelines around the use of telehealth to include platforms that typically historically had not been considered HIPAA compliant, things like Google Hangouts and so on, are now allowed. I think most people are also aware that the guidelines around home dosing, specifically of methadone, take-home dosing of methadone, have been relaxed to facilitate ensuring that people have access to care. Some of the things that may be less well known are that DBHIDS, our Division of Community Behavioral Health, which is our managed care arm, had done something that I think was pretty innovative, which is switch from a fee-for-service retrospective billing reimbursement system to a prospective payment system, in which essentially what CBH did was to program fund these all providers across the network throughout the early and the middle phases of the COVID epidemic. To give you a sense of why that is important, think about the fact that for many providers, all businesses, including not-for-profits, the lifeblood of any business is their finances. It's having cash. And during COVID, there was clearly I wouldn't say a reduction in demand, but certainly fewer people able to come in physically to get services. And so for programs that really needed cash, it was going to be difficult to bill enough to sustain operations. And so this was, I think, a particularly smart move in supporting our providers to be able to pay staff and continue to run their programs. We also targeted a lot of efforts towards the homeless population because, again, this is a population that's at significant risk. Many suffer from comorbid mental health, addiction, and medical issues. And so I'm sure people on the call have heard about the Holiday Inn Express, which is the city-funded, city-operated quarantine site. And this was purposefully built and developed for individuals, primarily with homeless individuals who were unsheltered, but also people who were unsheltered and tested, and either had tested and were pending results for COVID or actively had COVID symptoms. And so that was, I think, a major intervention for that population. Other things that DBHIDS has been involved in, if you think about policy as a tool for advocacy, and also as a sort of setting quality benchmarks, DBHIDS has been involved in a number of those, including providing guidance on shelter, on developing quarantine and isolation space within facilities. That work continues. It's an evolution. In the beginning, at the very beginning of this in March, we didn't have very many providers at all that had outbreaks in facilities. I would say now that it would be the exception rather than the rule that facilities, congregate settings have not had outbreaks either among the staff or among the residents to some extent or other. So these are, I've sort of gone in reverse order, but these are some of the high level system interventions that DBHIDS has done and continues to do. Now, in terms of, I would say, so populations can be defined. We have the entire, obviously the entire population of the city of Philadelphia. And then to Dr. Purtle's earlier points, we can think of populations in very specific and defined ways. So returning citizens would be one such example. These are individuals who have been incarcerated, many of whom we know have mental health and addiction or related conditions. And so this is an exceedingly vulnerable population. Not only have the rates of infection, COVID infection being higher in congregate settings in general, but upon return, many of these individuals become homeless upon release. And the release was, I think, thoughtfully done and necessarily done, but the DBHIDS has been involved in efforts to engage these individuals, these returning citizens, maintain access to services, and ensure that they are safely and securely housed. I already talked about the quarantine site as an example of a targeted response to COVID. We've also leveraged DBHIDS historical investment in peers in multiple ways. So one way would be programs in Kensington, which there's a huge cluster of extremely vulnerable individuals, and also at the quarantine site, and also with our outreach teams. I would say one of the more important things that DBHIDS has done throughout this pandemic has been really supporting the mental health of our frontline workers, both our own staff, which is a considerable number of individuals, but also externally within the city. So just this afternoon, before this, about 2 hours before this, we were on a call with our residential facility providers and reviewing wellness tips and wellness strategies with them, and also sharing multiple resources for that population to access. Again, this is the frontline staff, many of whom have had to deal with extended hours, work outage, losses of some of their colleagues to COVID. And so we see this as really important work, as well as not just now, but on an ongoing basis for the foreseeable future. And I think my last point would be significantly expanding our capacity for crisis work and suicide prevention. DBHIDS operates the provider crisis line, which is the also historically has been called acute services, basically a call center where any citizen of Philadelphia can call in and request assistance if they're in crisis. And so we've increased our capacity within that resource. That team also does mobile crisis dispatch, mobile team dispatch, and also assists with 302s when those are necessary. One of the more heartwarming stories that I've heard in the last week was one of our team members collaborated with another team within the city to get assistance to an individual who was really actively in the process of ending their own lives, and they were able to get help to that person and interrupt that event, and that person is still alive today. So that was good to hear. Let's pivot for a moment and talk about the world post-COVID. I think that earlier schematic of the iceberg was absolutely on target. If we look at historical data, for example, from the Great Recession, there's some reports that with every 1% increase in unemployment, there was this is something I read just today, there was a 1.6% increase in suicide rates. There is obviously somewhat of a lag in terms of the mental health impact of COVID, but multifactorial, of course. Some of the things I talked about earlier, a lot of people living with or dealing with loss, deaths of loved ones, a lot of people dealing right now with unemployment and the economic impact of that. People who already have pre-existing mental health conditions. Some have not been able to access care. Unfortunately, but I think the majority here in the city, there's plenty of access here in the city. But for other people, just the very existence of a condition like COVID, or which is frankly potentially an extinction level event, is enough to worsen pre-existing anxiety or depression or OCD or trauma. And then finally, we also know that the prevalence of domestic violence has gone up worldwide as most countries have enacted this lockdown. So lots of reasons for the demand for mental health services to go up. And so what we see going forward is a need for grief and trauma counseling, and there are a number of resources that already have been rolled out across the country. There are a number of resources targeted at providers here in Philadelphia, and others that have been rolled out on the national level, and more of those continue to be put in place. One big opportunity that we have is to take a look at our crisis system, which this work has already begun at DBHIDS. Over the past years, the first phase of this was implementing additional resources around children's crisis, which included things like the Children's Crisis Center, this Children's CRC at Belmont, and CMI's teams, Children's Mobile Intervention Services, and CMCT, Children's Mobile Crisis Team. And those have been up and running, but this is an opportunity to review and expand those. I know we've certainly been talking about trauma responsive treatment for a long time, and this is again I think this situation really calls for more of that. And then as I talked about suicide, suicide earlier and historical trends, and we know that across the board, suicide rates have steadily increased over the last about 15 years. DBHIDS has been involved in a number of efforts around that. We're part of the Suicide Prevention Task Force here in Philadelphia. And here, actually just a couple of weeks ago, onboarded a suicide prevention coordinator and are involved in multiple other activities in that regard. And then to revisit the point I made earlier, I think we are still in the middle of an opioid crisis that has not gone away. Lots of effort around that, but we also know that hidden within the opioid epidemic is an epidemic of deaths from stimulants, overdose, and also more recently there appears to be some uptick in alcohol use during the COVID era. And I already talked about frontline worker health and wellness. Let me just share one resource with everybody. This is a snapshot, really, a screenshot, really, of one of our tools, our portal for the city. This is Healthy Minds Philly. Multiple resources around wellness, and you have the ability to take health, a screening test on there. Lots of resources and material. There's a health blog. There's lots of events posted there. I would encourage you to consider using this as a resource and sharing this along with your network. And if you need to contact me, this is my email, and I'll just stop there. Thank you.
Wonderful. Thank you so much. So we have 2 minutes left. We don't have any questions in the question box. So I have one question. I love each of your thoughts. And thank you again for your wonderful presentations. So all signs point to the need for mental health services increasing as COVID ends, if we can say that. But moving forward, an increased need, hopefully an increased demand. But we already, pre-COVID, we had capacity problems and not enough mental health service providers. And I'm just curious for your thoughts, and if you have thoughts on how we, saying that very, very broadly, we might address that and be able to provide services to everyone who might need them and want them with a shortage of mental health service providers.
So I think let me lead in by saying this. I think broadly across the world, and certainly across the United States, there is a dearth of mental health resources. I will say, however, in Philadelphia, on the publicly insured side, there is ample capacity. And actually, if you look at where the needs appear to be, coverage on commercial insurance coverage tends to actually lag behind public insurance, that is Medicaid, within the city of Philadelphia. That said, I do think that the city has done a lot of work to improve capacity, certainly around addiction treatment. Yeah, but that's an ongoing process. Let me say also that one of the interesting findings, preliminary findings from studies across the country has been an increase in utilization of behavioral health services. As you might know, historically, no-show rates for outpatient treatment tended to hover around 30%. So 30% of slots would not be filled. Those numbers have dropped sharply during the COVID, with telemedicine now. So those rates, I've heard figures hover from anything like 5 to 10%, which is unheard of. So I think there is increasing utilization. I think there is, we probably do have work to do around, access. Certainly, I think the work around quality continues. But I'm sure that I think there's historically always been some unused capacity, is what I would say.
Thank you.
Yeah, and so what I would say is I think that, we do know that there are, as Dr. Shoyinka just stated, there's a dearth of particularly child providers. And what we've been trying to do prior to COVID-19 was really think about ways that we could be innovative and creative and provide services. So a lot of that's been through various integrated care models. So some of that has been a telephonic response, talking to pediatricians about the concerns of the children they're seeing in their practices, and giving them assistance on the spot, and trying to help them consider whether or not those children can be served by a pediatrician with psychiatric or psychological help, or whether they need to come into a subspecialty clinic. We also at CHOP have integrated care practices where we have child psychiatrists and psychologists embedded into pediatric practices. So I think those are ways in which we were trying to work around the decreased amount of child providers for the children that may need our services. And I think moving forward, those things will continue to happen. I mean, they continue to happen now in the midst of the pandemic. And again, to piggyback on what Dr. Shoyinka just stated, that we also will continue to use tele-platforms, which have been, for many families, able to provide services for families that were in rural regions that was used prior to the pandemic. And now, again, I think that the fact that some people are using that modality will make its ease of use just better for everyone who needs that particular service.
Great. Thank you. We have a number of questions trickling in. It's time. I hear some children in the background, I think. I have my children in the background. If you don't mind, I'd love your thoughts on one question. There was the first question, and I was curious. I think it gets at an interesting question. And the question from Gianna, and I won't rephrase the question, but I think the question gets at for group modalities. She's talking about an Alcoholics Anonymous meeting, where the group is the essence and the modality of healing, if you will. Have you observed any workarounds to that? What are the thoughts on things where it's group therapy, but in the age of social distancing, how those could be carried out safely? Have you seen any, those sorts of groups going online to Zoom? Dr. Njoroge, you mentioned community video visits, and I flagged that. I wasn't sure what that was. Perhaps that gets at this to some degree. But yeah, how could we, have people heal together in this age of right now of social distancing?
Yeah, so I think there were a couple of things. So I was talking about the Mays Landing community-based practice where they actually do group interventions. Now, let me state that it's clearly very different than Alcoholics Anonymous in that the anonymity, many of the things that are specific to those particular groups and communities don't necessarily exist when I'm talking about the groups that children and adolescents attend. But for the most part, with that population, specifically children and adolescents, have done well with group-based therapy. And they just have done basically what we're doing now, which is have shared screen. Now, the groups have not necessarily been up to 20 participants. They may have been 14 or 15. And again, these are teenagers or school-age children. So there are some differences. There also have been parent groups that have been able to meet using tele-platforms. So I think that I will toss this back over to my colleague to talk specifically about the population with a substance use, because of that there are some, I think, qualitative differences in the way in which those groups meet and the frequency that may differ a bit from children and adolescents.
Yeah, thank you, Dr. Njoroge. I think that's an excellent question. Let me piggyback on your comments, which is I'm hearing reports across the board of group therapy being done using video conferencing very successfully with various different populations, adults, children, and so on. I just posted a link to essentially a group therapy forum for health workers here in the city of Philadelphia, which is being run by Springfield Psychological Associates. It's basically group therapy for health workers. And if you register and log on, they actually have a session this evening. I think it starts at 6 p.m. and it follows all the tenets of a group therapy session. Specific to, I would have to go back and look at more information around how this has been specifically used for groups like AA or NA, but I can't imagine that it's not being tried in some shape or form during COVID.
Wonderful. Well, thank you so much for presenting and for your time. Thank you, attendees, and everyone stay safe and be well. Thanks.
Well, thank you.
Thank you.
Everyone.
Thanks for inviting us.
Bye-bye.
Good night.